This slide just shows the differences in the size of the airway between a newborn and an adult. So the picture shows the effects of a 1 millimeter edema around the circumference of a newborn and a child's airway. If 1 millimeter of circumferential edema develops in a newborn, it will halve the airway radius. So the airway diameter has been decreased by half. In the adult, the same amount of edema will decrease the diameter only by 2 millimeters. So in an adult, 1 millimeter difference in diameter size isn't that much of an issue, but it's a huge issue in an infant and young child. Again, with increased resistance, there's increased risk of atelectasis. So please just consider those anatomical differences and be very vigilant with respiratory issues. We talked earlier about those eustachian tubes and how they increase the potential for ear infections. Well, the eustachian tube, which extends from the middle ear to the pharynx, in an older child, or as in us, that eustachian tube tends to be tilted to help drainage. But in the younger child, the infant in the younger child, that eustachian tube tends to be more horizontal. So you can imagine the potential for growth of bacteria in this nice, dark, warm, moist space. That's why children tend to have more ear infections than adults. So this picture shows the diaphragm as well as the respiratory system from ages of newborn to adult. You can see the tongue gets smaller, the lungs get bigger, the alveoli increase in number, the diaphragm changes shape, the neck gets longer, the trachea gets longer as the child ages. All this helps to maintain our airway, but it's not present in a young child. The alveoli increase in number for the first 5 to 8 years of life. After that, they tend to more increase in size and complexity. Notice that diaphragm in the infant compared to the adult. The horizontal attachment of the ribs results in a flat diaphragm. So this causes the diaphragm to be working at a mechanical disadvantage. But remember that the babies are diaphragmatic breathers. So even though the diaphragm looks little, it's a major factor in breathing when they are little. So the bottom line, any condition that increases or decreases compliance or the ability of the lungs to stretch, or increases airway resistance, i.e. narrowing due to edema, etc., results in increased work of breathing. For example, increased respiratory rate, presence of retractions, nasal flaring, and use of accessory muscles. When respiratory muscle fatigue develops, respiratory failure can occur. So it's our role as a nurse at the bedside to prevent this respiratory failure from happening by doing a good assessment of the child's status so that we can intervene before danger occurs. So the manifestations of respiratory failure, or what you're going to assess for pending respiratory failure, are vary, as this slide depicts. Please always remember that the level of consciousness is one of your most important assessments. The cardinal signs are always present, but please remember that they may be present in other circumstances. So restlessness, tachypnea, tachycardia, diaphoresis can be present with anxiety, pain, boredom, as well as pending respiratory failure. The evaluation of respiratory dysfunction is based on the clinical assessment and labs, especially ABGs. But the problem is, by the time you get the labs back, the patient might be dead. So your clinical assessment is paramount. Paramount. All right. Respiratory dysfunction may be abrupt, or it might be insidious. That is chronic, occurs over a period of time. Signs of respiratory distress are subtle. Most clinical manifestations are nonspecific and are affected by variations among individual patients and differences in the severity and duration of inadequate gas exchange. So gradual and more covert development of signs and symptoms are less easily recognized. But nursing observation and judgment are vital to the successful management of respiratory failure. Nurses must be able to assess the situation and initiate appropriate action within moments. The unknowing observer may attribute early signs such as mood changes and restlessness to other causes, and some signs can be altered by other factors. So the bottom line is you need to do a good assessment. Every time you look at your patient, you're doing the pediatric assessment triangle and looking for changes from your previous assessment to this assessment. Remember the use of that pediatric assessment triangle. That is vitally helpful. That is a great thing to keep in your toolbox. Know that LOC is level of consciousness. We've talked about that already. DOE is dyspnea on exertion. Nasal flaring, what happens is the opening of the nose spreads open while breathing, which indicates that the person is having a harder time to breathe. A grunting sound can be heard when a person exhales. The grunting is the body's way to try to keep air in the lungs, particularly in the alveoli, so that they'll stay open. Respiratory failure is the most common cause of cardiopulmonary arrest in children. Respiratory arrest, of course, is a complete cessation of respiration. Respiratory failure can occur as an emergency situation or may be preceded by a gradual and progressive deterioration of the respiratory function. So why does respiratory failure lead to death and not heart failure? The answer to that question is because children have healthy hearts, unlike adults. They haven't been exposed to all of that environmental influences that adults have, as well as those risk factors that adults partake in that cause their hearts to fail. So also consider tripoding, which helps to increase the diameter of the chest wall, allowing for more air to enter. This occurs with sitting, and the arms are used to help support their chest. This can occur in the early or severe hypoxia. So please be aware of the early and less obvious signs of respiratory failure, as well as the signs of more severe hypoxia. And last but not least, what are we going to do for respiratory distress? Well, it depends on the clinical signs. We just spoke about most clinical manifestations are nonspecific and affected by variations among individual patients and differences in the severity and duration of their inadequate gas exchange. So a gradual and more covert development of signs and symptoms is less easily recognized. So there's no black and white answer as to how to manage respiratory dysfunction, other than to do what? Begin with your ABCs. And I promise with practice, the interventions will just be second nature. So when they're with mild respiratory distress, you can use oxygen via nasal prongs. So mild is, the patient's color is still good, but perhaps their pulse ox is a little bit low, maybe low 90s. Maybe their respiratory rate's a little elevated. Maybe their heart rate's a little elevated. The use of nasal prongs is particularly important with infants because then they still have their mouth open for that need for their sensory. Remember Piaget's and the sensory motor stage where they like to put everything in their mouth? So an infant can still be sucking on their pacifier with their nasal prongs. You could also use an oxygen mask, but we tend to use more nasal prongs. When it gets to be not so mild, and by not so mild, maybe a little bit more pale, saturations maybe in the high 80s, heart rate still elevated, respiratory rate still elevated, maybe there's some decreased level of consciousness, maybe there's some anxiety going on, some signs of irritability. Well, that's happening because they can't breathe very well. So the interventions you could do are to supply the oxygen with a non-rebreather, as pictured in this slide. You could open the airway by repositioning them. So again, if they are lethargic, they can't really use that reflex for position of comfort. So you help them to reposition themselves so that they can breathe better. Stimulating them. Perhaps they're sleeping, and if you wake them up, then they wake up and they breathe better. All right. If they have some type of congestion going on, don't ever hesitate to suction, either with the mushroom tip catheter or the nasal pharyngeal catheter. because perhaps they have some type of respiratory infection going on, causing a buildup in mucus, which is occluding their airway. And also, they can use humidified high flow nasal cannula, which is what we use when children are in the later stages of respiratory distress. So it's a step down from being on a ventilator. It delivers heated and humidified blended oxygen and air via a nasal cannula at high flow rates greater than 2 liters per minute. It is adjusted based on their weight and clinical appearance, creates a small continuous positive airway pressure, and it also flushes out the anatomic dead space, air ventilation, and decreases airway resistance. So obviously the end goal is improved gas exchange and decreased respiratory rate and decreased work of breathing. When you do have patients on humidified high flow, it's been my experience respiratory therapy handles it. And, if they're really in severe respiratory distress, you start CPR and call for help, right? So severe respiratory distress, now they're becoming hypotensive, their respiratory rate's declining, their oxygen sat is in the low 80s, high 70s, they are probably obtunded, maybe stuporous, that is, it's really difficult to rouse them. Don't ever hesitate to call for help, all right? And also, it's important to consider their history. There's many children out there that have these crazy disease processes going on that impair their neurological response, and as a result, they have a decreased ability to ventilate themselves. Their lung muscles just aren't very strong. So for many children in this condition, it's normal for them to have what we would call junky lung sounds. That is, their lungs just sound terrible. So when this occurs and you're listening to their lungs and you're thinking, oh my gosh, what's going on? Don't ever hesitate to ask the caregiver, are their lungs always junky? And if the caregiver says, oh yeah, they usually sound like this, wow, that's relief, right, for you? But if the caregiver says, no, their lungs are usually really clear, that's a problem, all right? Also, there are some cardiac issues, which we'll talk about later, who typically have saturations in the 80s. So you have to be aware of their history. Don't ever hesitate to ask about their history.